Hi everyone, thanks Lauren. Thank you for everyone for joining us tonight. I'm Sarah Sweeney and I am the Value-Based Care and Innovation Manager at St Vincents Health Network, Sydney, and I work within the newly formed Innovation and Improvement Directorate. We are really excited to be able to present to you all this evening on a project we've been working on here at St Vincent's Hospital and the public over the last 12 months. The Direct Access Colonoscopy service is part of the Ministry of Health's Leading Better Value Care initiatives. The Leading Better Value Care programs are part of the Ministry of Health's priority to accelerate the move to value-based care. It's a statewide priority program that aims to improve the health outcomes and experiences of people with specific conditions or risk factors. The Leading Better Value Care program, also known as LBBC, aims to improve the experience of providing care, improve the efficiency and effectiveness of care, and take a systematic approach to embed evidence-based, patient-centred models or standards of care, which can be tailored at a local level. Within the St Vincents Health Network Sydney, we have been implementing these programs along with the state since 2017. And part of the initiatives is partnering with some of the health pillars, including the Agency for Clinical Innovation, the Clinical Excellence Commission, and our fellow colleagues we have online tonight from the Cancer Institute. By bringing together the leaders from the primary healthcare networks, community and acute care settings, the aim of all these programs is to promote an integrated health system and create appropriate platforms for LHDs and specialty health networks to share information, ideas and learnings. As part of the Direct Access Colonoscopy service, we've been able to work through, I guess, a lot of our local implementation issues, but really aim to promote a program that increases access for our patients and also improves the experience of their care. So I won't take any more time because I'll leave it to the experts, but I'll hand over to Brooke Selby now, who is the implementation lead of the Direct Access Colonoscopy program at the Cancer Institute, to introduce her team.
Thanks, Sarah, and thanks everyone for joining us this evening. As Sarah mentioned, I am the implementation lead for the Direct Access Colonoscopy initiative at the Cancer Institute New South Wales, and I've been working alongside my colleague Laura Goodsawad, the Senior Research and Evaluation Officer at the Cancer Institute. And sorry, Laura, I just realised I introduced you. And while I'm on a roll, we have Christopher Horn, the New South Wales Bowel Screening Program Manager, also at the Cancer Institute, and Rose Boutros, the Participant Follow-Up Function Manager. And I'm very grateful that they've taken the time this evening to speak with you about their respective parts of the project that they work on. We have quite a packed agenda this evening. As I mentioned, we have a few guest speakers, and then further towards the end of the evening, Helen and Sarah and David Williams will be presenting on what direct access looks like at St Vincents Health Network. I think Sarah gave a great introduction, so we might be able to skip over this slide, which is great, unless you had anything else to add, Sarah.
No, I think just to say that as we move, I guess, where health becomes more expensive, we're looking at, I guess, programs that add value to the patient and to what actually matters to them, and trying to shift, I guess, away from the very much that volume-based model where you just see a patient because they booked in for another appointment.
Great, thanks, Sarah. So I'll hand over now to my colleague Christopher Horn to speak about the National Bowel Cancer Screening Program and bowel cancer in New South Wales. Thanks, Chris.
Good evening, and thank you for the invitation to come along and speak tonight. I think this is a really important topic, bowel cancer generally, and I know a lot of you will be aware of the statistics of bowel cancer in New South Wales and in Australia, but this is a really important intervention that we've helped put in place to try and roll out and sustain across New South Wales and I think the work that they're doing at St Vincent's is excellent. So I'm going to give a bit of an overview of bowel cancer in New South Wales and some of the work that we're doing, and then some of my colleagues will talk a little bit more specifically on the work that they're doing. If people were not aware already, bowel cancer is the second most common cause of cancer mortality in both Australia and in New South Wales. But we know that awareness of this amongst the general population is quite low. We expect a projected roughly 6,000 deaths in New South Wales in 2021 from bowel cancer. So that works out to be about 115 people per week. For that reason, and because of the impact that we can have by applying what we know, bowel cancer is a focus cancer of the cancer plan for New South Wales. So it's one of 3 primary cancers for which we have a really specific focus. So we work along the entire bowel cancer pathway from awareness, screening and prevention, through to diagnosis and treatment, as well as follow-up and survivorship as well. Different parts of what is actually quite a large organisation work along the different parts of that pathway. Slide, please, Brooke. So this slide really demonstrates why we do screening. This is the 5-year survival for bowel cancer across the 4 stages. Stage 1 obviously being the earliest stage of diagnosis, and when we talk about early stage, we're typically talking about stage 1 and 2, but if we look at the stark difference between stage 1 and stage 4 diagnosis, stage 1 currently has a 5-year survival of almost 99%, where stage 4 has a 5-year survival of roughly 14%. So bowel cancer typically grows slowly and often without symptoms for quite some time, and one of the only ways to detect it is actually early before it's symptomatic is using a screening test, which is actually looking for microscopic blood in the poo that is often shed by polyps or sort of precancerous growths. So screening is the best way to pick it up early. We know that being over 50 is actually the biggest risk factor for bowel cancer for the majority of the population, and the National Health and Medical Research Council endorsed guidelines recommend that people screen every 2 years from the age of 50 if they're at normal or slightly elevated risk of bowel cancer. So to that end, the National Bowel Cancer Screening Program has been rolling out. It's actually been rolling out for a very long time, but that was accelerated over the last 5 years since 2015. And we are at full implementation now. So all eligible people in Australia aged between 50 and 74 are invited to complete a bowel cancer screening test at home every 2 years. So the kit is sent to people to do in their home. They need to take 2 samples and send them back by post to the lab. The kit is completely free, and the results are sent to them they should receive the results from their test within 2 weeks. And the instruction is always to follow up a positive result with their GP. Where they've nominated their healthcare professional on their participation form, those results are also sent to the GP as well, so that if that participant has not followed up, the GP has the opportunity to contact them and say, you know, come in, have a talk, we need to look at what the next steps are. Next slide, please, Brooke. So the Cancer Council, some researchers at the Cancer Council undertook research which they published in 2017, which is the Lou paper, where they used a microsimulation model to look at and demonstrate the impact of screening at 3 different sensitivity points. So currently we have approximately 40% participation in bowel cancer screening across Australia. That's slightly lower than that for New South Wales at about 39.3. So roughly 2 in 5 people. We had them take that modelling and look at it at a statewide basis as well. So looking specifically at New South Wales in the period 2015 to 2040. So they modelled us 2040, so 25 years. They modelled that for us, and we know that at the current screening rate, bowel cancer is going to save approximately 17,000 lives over that 25 years. If we can increase the participation to 3 in 5, or roughly 60%, that will save an extra 8,000 lives. So about 25,000 lives saved in 25 years. So that's because we're picking up cancer at an early stage, but in actual fact, we can pick it up before, you know, precancerous adenomas and things, certain changes before they've actually turned into bowel cancer. For people who register a positive result, go on to have their colonoscopy and can then be put on surveillance programs or have that pathology identified early. So for many people, it may not even result in a bowel cancer diagnosis. Of course, people participating in the program and doing the tests and then being diagnosed via colonoscopy or making it through to treatment does rely on them being able to access timely colonoscopy. The NH&MRC guidelines recommend a diagnostic interval so that the time between first healthcare presentation, typically with their GP, and colonoscopy does not exceed 120 days. The evidence, they believe, suggested that there was highly unlikely that there would be clinical progression within a 120-day window. However, we cannot currently measure what that window is in practice because we know there's time lost in seeing a GP, there's time lost in referrals reaching hospitals. And so one of the things that the information we've gathered through this project has shown that actually for a lot of people, their time, that diagnostic interval is actually exceeding 120 days. So it's really important that at the hospital level, that we are aiming for the 30-day window, so that the category A, which is what has been endorsed by the statewide guidelines development work that's been done this year as well. Slide, please, Brooke. In addition to the morbidity and mortality benefits that come with better bowel screening participation, there is also a measurable economic impact as well. The treatment costs for stage C bowel cancer are approximately 2.5 times the treatment costs at stage A. So if we simply talk in terms of people who either won't get through to the cancer treatment end because they have their polyps or their precancerous growths picked up early, or they get diagnosed at an earlier stage. So in that sense, there's a lower cost to health and to cancer services, but there's also the knock-on economic impact as well for people who are living healthily at home and continuing to work, as well as not having to take time out to go to treatment. So there are cost savings as well as the morbidity and mortality benefits at most of the stages along here. Slide, please. So the participation in the National Bowel Cancer Screening Program is about 36.5%, so slightly below New South Wales, but reasonably in line. New South Wales is placed ahead of only the Northern Territory in terms of participation. Now we are as far ahead of Northern Territory as we are from the leaders, which are Tasmania at 47.8%. Most of the LHDs and PHNs in New South Wales are within about 5% of that statewide average. But you know, the increase in participation is really, really critical to getting people diagnosed early and saving lives. I'm going to leave it there and hand over to my colleague, Rose Boutros, who's going to talk about the participant follow-up function, which is a part of the National Bowel Cancer Screening Program that is run by each state and territory individually. And so that's a team that we run at the Cancer Institute New South Wales, in addition to the Direct Access team, which is the work that Brooke is leading, and the other work we do, which is around engagement with different communities and the campaigns and TV ads that we run to try and increase that participation rate. So I'll hand over to Rose. Thank you.
Thanks, Chris. So the participant follow-up function complements the National Bowel Cancer Screening Program in a number of ways. Firstly, we encourage participants with a positive FOBT result through the screening pathway by providing knowledge and support to participants around the importance of follow-up and early detection for best treatment outcomes. We also liaise with and build relationships with primary health providers, including GPs, their practice nurses and admin staff, in addition to local health districts, to both gain information about participant progress along the pathway and also to encourage GPs to refer their patients to a specialist for colonoscopy. So all the information gained during follow-up is added into the National Cancer Screening Register. We also contribute to and maintain the awareness of the program to both participants and healthcare providers and maintain the reputation of the program. We contribute to quality improvement aspects of the program as well. So for example, the PFUF's involvement and feedback into both the development and ongoing operations of the National Cancer Screening Register. Next slide, please, Brooke. So this slide is just an overview of the current screening pathway, and it highlights the contribution of PFUF, shown here in green at 4 different stages of the pathway, for participants who return a positive FOBT result. So that's shown at the top in red. So there are 2 main areas for PFUF to complete follow-up. The first on the right is at the GP visit stage. So after a participant receives their positive FOBT result, by letter, they also get a recommendation to go and see their GP within 2 weeks. And once this doesn't actually take place within a given time frame, another reminder letter is sent, and then following that, the participant is added to our work list for follow-up. So there's 2 opportunities at the GP follow-up stage for PFUF to interact with participants and their GPs to encourage them along the pathway. At the colonoscopy stage, once the program has received information that a GP visit has occurred, whether that be through interactions with PFUF or by the GPs or participants returning that information to the program directly. Again, there's further reminder letters sent to the participant and their GPs, after which point PFUF contact the participants and GPs in addition to the LHDs and specialist rooms to encourage progress through the pathway. So far PFUF have followed up over 90,000 participants through this pathway over the last 5 years in New South Wales. Thank you.
Thanks, Rose. And Rose will be on the line towards the end of the call if anyone has any questions about the role of the participant follow-up function officers in their area and what they do. So I guess just in summary and to provide some context and frame the challenge which direct access colonoscopy aims to address, I thought it would be valuable to briefly summarise the current colonoscopy landscape. And so we know that the total number of colonoscopies performed in New South Wales over the last 10 years has increased by 50%. Colonoscopies as a result of the National Bowel Cancer Screening Program account for a small proportion, approximately 9 to 11%. It's important to note that this does exclude GP-initiated tests. And it's our understanding currently that LHDs have limited ability to quantify the amount or the number of GP-initiated tests, as well as the number of National Bowel Cancer Screening Program tests that are coming through their service. And currently the national screening positivity rate is approximately 8%. And so while colonoscopies for positive FOBT patients account for a small proportion of the total number of colonoscopies performed, the increased demand for colonoscopy overall significantly impacts access through increased wait times. In order to continue to reduce the incidence of bowel cancer and reduce healthcare costs to both the healthcare system and the patient, patients require timely access to high quality colonoscopy. And I think it's important to acknowledge that there are many factors that impact on an LHD's ability to deliver timely access to colonoscopy. And certainly further on this presentation, we'll talk about the external factors that impact patients' ability to access colonoscopy as well. Direct access colonoscopy has been included in the Leading Better Value Care program due to the success of the Cancer Institute's Direct Access Colonoscopy grant program. The program has involved funding a series of 13 grants since 2014, which have all demonstrated promising reductions in wait times using varying models of care. The initiative has, I guess, 2 arms to it: the statewide implementation of direct access colonoscopy services for patients with a positive FOBT, and looking at ways to improve triaging and prioritisation of colonoscopy waitlists. A key advantage of direct access colonoscopy is a reduction of delays for someone where the diagnosis of exclusion is now cancer, through the removal of the initial specialist consultation and introduction of nurse-led telephone triage and assessment. A study performed by one of our direct access colonoscopy grant sites and the most mature DAC model in the state found that approximately of 1,000 patients referred into a direct access colonoscopy service, approximately 60 to 70% of those patients were appropriate to continue along the direct access pathway. And so what that means is that 60 to 70% of patients met the inclusion criteria determined by the local health district. This potentially demonstrates how direct access colonoscopy can free up outpatient clinics and certainly outpatient appointments in private rooms, which is a great bonus, I think. On the right-hand side of the screen, we can see the key features of a direct access service, which differentiate it from other models of care. I guess the more defining features being nurse-led assessment and direct access colonoscopy booking. Just go back. I won't spend too much time talking about the role of GPs in regards to direct access colonoscopy because Helen will speak to that a bit later on. But from my perspective and the perspective of the project, the role of the GP in a direct access model is to provide patients with information about the pathways available to them and have that balanced and objective discussion about the pros and cons of each pathway, and certainly keeping in mind obviously where this is clinically appropriate. GP's role is to provide adequate information when referring into the direct access service to allow the triage nurse to be able to assess patients' suitability to continue along this pathway. And we know anecdotally that often that direct access nurse, in this case it's Helen, they develop a really great relationship with the practice managers and the GPs in their local area, because often it's a back and forth and exchange of information to be clear about those patients' comorbidities and their suitability to continue along the DAC pathway. And lastly, the GPs will certainly, as they would normally, follow up on the outcome of the colonoscopy and act on any recommendations regarding a surveillance protocol made by the specialist. I think Sarah did a great job of explaining sort of that quadruple aim at the beginning, but the quadruple aim certainly underpins many of the objectives of the DAC initiative. And through the implementation of direct access services, we hope to be able to improve health outcomes for patients through increased detection of early stage bowel cancer. We hope to improve the experience of patients receiving care through reducing anxiety and distress. And we know this is typically experienced by patients when they are waiting for colonoscopy for lengthened periods of time. And by removing the initial specialist consultation, the direct access model eliminates barriers to access, including out-of-pocket costs, transport, and lost income due to taking time off work. We hope to improve efficiency and effectiveness of care provision, I guess at a systems level, as well as at the clinician level, allowing clinicians to redirect their time to more complex patients and certainly reduce volume of low value activity in their private rooms and sort of in clinic, so removing those low value colonoscopies from the wait list. And we also hope to reduce wait times from the date of the test to colonoscopy overall, and certainly the date of the test to when that patient will see the GP too. And just lastly, I thought I would mention one of the two key deliverables that we have launched or delivered this year as part of the Direct Access Initiative, and that is the Direct Access Model of Care. And in 2019, we brought together a group of key stakeholders, including clinicians, direct access colonoscopy coordinators, representatives from the Agency for Clinical Innovation Gastroenterology Network, and representatives from the Australian Commission on Safety and Quality in Healthcare to come together to formulate, I guess, a guide to support LHDs to implement direct access colonoscopy locally. The document outlines the mandatory and recommended inclusions for local implementation, but it does also provide a level of flexibility that allows LHDs to adapt inclusions to their local context. The direct access model of care aligns very closely with the Australian Commission on Safety and Quality in Healthcare Colonoscopy Clinical Care Standard, and should certainly be read in conjunction with a number of other guiding frameworks which are included in the document. And this is just an example of the format of the document here. I don't believe that this has been circulated, but you're able to find this on the Cancer Institute website. And now I'll hand over to my colleague Laura, who will speak about baseline data collection, or data collection more broadly, in regards to the Direct Access Colonoscopy Initiative.
Thanks, Brooke. So around the end of last year, all local health districts and specialty health networks completed baseline data collection. And this served two purposes: to enable us and the districts to have a better understanding of the current colonoscopy landscape and enable localized implementation of DAC, and also to allow us to evaluate the impact of the DAC initiative by comparing indicators after implementation to findings from before implementation. So this involved a review of medical records of a sample of patients who'd recently undergone a colonoscopy, and also fielding of a patient-reported experience measure, or PREMS survey. So I'll talk first about a couple of the findings from the medical record review. If we can go to the next slide, please, Brooke. So one of the indicators included in the medical record review was triage practices, and the triage category assigned on the request for admission and in the theatre management system. And so these two charts show the triage category in those two, on the RFA and the theatre management system at St. Vincent's. And the blue is the patients who had a positive FOBT indication, and the green is all patients included in the review. And so you can see that for patients with a positive FOBT at St. Vincent's, when this review was undertaken, three were triaged at 30 days, 3 at 90 days, and 1 at 365 days. And this was pretty consistent in the theatre management system as well, with just 1 patient being moved from the 30-day into the 90-day category. You can go to the next slide. The other thing that was looked at in the review was wait time for patients with an FOBT. And this was across a couple of different indicators. So date on the GP referral letter and date the GP referral letter was received, date the RFA was lodged, and the date of the colonoscopy, and days between the date the GP referral letter was received and the date of the colonoscopy. And this table shows the average days for St. Vincent's Hospital and the statewide results. So this includes all records that were reviewed by local health districts and specialty health networks across New South Wales. And so across the state, this was 59.1 days on average between the date the RFA was lodged and the date of the colonoscopy. And we'll just note that in this chart for St. Vincent's, you can see that the days between RFA lodged and colonoscopy is a bit higher than the days between the date the GP referral letter was received and the date of the colonoscopy, which might seem a bit counterintuitive. And this is just a result of it being a relatively small sample size. And so one of the records which was included in the review didn't have a GP referral letter receive date available, so it was excluded from that value, but included in the 75.7. So that is why you'd see those results. Thanks, Brooke. So these two charts show triage practices and wait times across New South Wales. So for all the local health districts and specialty health networks that completed the medical record review. And I acknowledge it's probably quite a lot of information and a little bit small for you to see. But I think the main takeaway is that we did find through this exercise that there was quite a bit of variation in both triage category, assigned and waiting times for patients with a positive FOBT indication across the state. Next slide, please. So here the top chart shows the setting of the pre-colonoscopy appointment for patients who come in for a colonoscopy at St. Vincent's, and it shows this for FOBT patients and all patients. And as you can see, there's a couple of different settings for the pre-colonoscopy appointment, including outpatient, private room, and direct access. And the table at the bottom shows the percentage of patients with a positive FOBT indication on both the GP referral and on the request for admission at St. Vincent's and at a statewide level. And as you can see, St. Vincent's is a bit above the statewide proportion for the indication on the GP referral letter, but a bit below for the indication on the RFA at 13% compared to 25%. I think something that's quite key to add here is that across the state, a lot of districts found it quite challenging to find the GP referral letter. So either because it wasn't included or attached to the patient records in the patient administration system, or because the patient had an appointment in a private room and that GP referral didn't sort of follow the patient through from the private room into the sort of hospital administration system for the public colonoscopy. And so for this statewide value, around 50% of GP referral letters weren't able to be found when they were doing their review of medical records. So that to an extent might explain some of that variation. We can go to the next slide. So this slide shows some of the findings from a baseline patient-reported experience measure survey that is being fielded from St. Vincent's currently, with the idea being to better understand what the current experience is for patients to inform implementation of the DAC initiative, but also to allow us to monitor and measure whether the DAC initiative, what impact it has on the patient experience. And so at the time that this slide was made, 89 PREM results had been returned across St. Vincent's, and of these 17 people self-reported that the main reason for having their colonoscopy was that they had a positive bowel screening test result. So I've pulled out a couple of key findings just based on these people who self-reported having a positive screening result, because it's of most relevance to this presentation. So when patients were asked how long they waited between being referred by their GP for a colonoscopy and actually having their colonoscopy, the majority, 60%, or almost 60%, responded that it was either less than a month or 1 to 2 months. But 4 of the respondents, 24%, responded that it was 3 to 4 months, and 1 responded that it was 6 to 12 months. And when patients who had a positive bowel screening test result were asked about the time between the referral and having the colonoscopy, the majority, 76% or 13 out of 17, felt that it was about right, whereas 1 person felt it was slightly too long and 2 felt that it was much too long. And so there was also a question included in the survey about barriers patients face following the referral for the colonoscopy. And 6 of the respondents with a positive bowel screening test result actually didn't find any barriers applicable to them. They didn't find it difficult at all. 2 were worried about the bowel preparation process, and 7 or 41% were worried about the outcome. And none of the patients who had a bowel screening test result said that they were worried about not knowing who to contact or speak to if they had any problems or questions, which is great. So I think this is my last slide coming up. So this, again, apologies that it's a little bit small, but this chart shows the responses for the question I mentioned just now in terms of whether the patient experienced any difficulty. But it shows the responses for all responses return to St Vincent's and not just those with a positive bowel screening result. But as you can see, the vast majority said they didn't experience any of the above, which is great news. And the most common responses after that were worrying about the outcome of the colonoscopy, worrying about the procedure, worrying about the bowel preparation process, and also arranging transport to and from the hospital. So that's it for my presentation on the data collected through the baseline DAC initiative. And I might hand over to Helen now to talk a bit more about DAC at St Vincent's.
Thanks, Brooke. Thanks, Laura. As you know, St Vincent's has recently commenced a direct access colonoscopy service. And this is a nurse-led clinic with specialist oversight, and it aims to benefit GPs. Actually, if you, Brooke, bring out the next, benefit to GPs by giving them an option to refer their patients to a public hospital, knowing their patients will be triaged and treated efficiently. There's benefits to specialists. If you just go back, Brooke.
Sorry, just to interrupt, Helen, there seems to be recording over the top of the slides. Are people able to hear that? Is that disrupting the presentation?
I can't hear anything.
Okay, we might press on.
That's fine for me.
Okay.
Okay. Can you just go back, Brooke? Yeah. Thanks, that's good. So benefits to specialists, again, and more consulting time available for other gastro patients. And the patients benefit as they are not required to attend for their initial consultation because this is done by a phone consult. And they're given specific information on colonoscopy and standardized bowel prep, and that's sent out to them as well. And they're able to liaise directly with the colonoscopy coordinator for additional information or rescheduling appointments. And the health system benefits from earlier detection of bowel cancer, which results in less hospitalization. There's also the implementation of the clinical practice guidelines for prevention, early detection and management of colorectal cancer. And this is to provide evidence-based recommendations and clinical guidance of bowel cancer care, including prevention, screening and diagnosis, and clinical aspects of treatment, follow-up and psychological care. Thanks, Brooke. The next slide. Yep, that's great. So for the GPs, it's really important to adhere to the inclusion criteria when referring patients to the direct access colonoscopy service because it is a nurse-led clinic. So this criteria, the inclusion criteria, includes patients aged over 50 and less than 74. They have to have no comorbidities and they shouldn't have had a colonoscopy within 2 years. The exclusion criteria, patients who have significant comorbidities are on anticoagulant therapy or have a BMI of greater than 35. And they will be required to see a gastroenterologist or an anaesthetist before the procedure is booked. And then patients with red flag symptoms along with a positive FOBT should be referred through the usual channels to a gastroenterologist in the outpatients clinic. The electronic referral form, which works with best practice and medical director, the GP software, they're downloadable from the Health Pathways site, and a PDF version is available on the St Vincent's website under gastroenterology. So it's really important to just complete all the sections of the referral, including sending the FOBT results, and all referrals should be emailed to svhs.gastro@svha.org.au. Participation in the screening program is not recommended for people with symptoms such as rectal bleeding or persistent change in bowel habits or with iron deficiency anemia, and nor for those who should be having regular surveillance or screening based on colonoscopy. Example for past colorectal cancer or adenoma, chronic inflammatory bowel disease, or a strong family history of colorectal cancer or a high-risk genetic cancer syndrome. Thanks, Brooke. So this is the flow diagram for direct access. So when the referral form is received by the colonoscopy coordinator, which is me, in the gastro department, they're screened to check the referral's complete, and then reviewed and validate the patient history. And so if they meet the criteria, then the patient's contacted for a phone assessment, and then they're checked for colorectal symptoms and the medical history to see if they're suitable for direct access. So this triaging process ensures the patient is booked for a colonoscopy within 7 days of receiving the referral. And for patients who don't meet the criteria, then an appointment is scheduled in the outpatient specialist appointment nurse-led clinic. And here the patient's medical health is assessed for his suitability for colonoscopy. In the past, the average time for referral to colonoscopy has been 56 days, as Laura showed. So we're endeavouring to book a Category 1 positive FOBT patient for colonoscopy procedure within 30 days in line with the colorectal guidelines. The guidelines recommend that it should be performed as promptly as possible after a positive FOBT to minimise the risk of psychological harm, although there's no evidence that prognosis is worsened within 120 days if cancer is present. So far, our data collected since the Direct Access Colonoscopy service began in March 2019 shows 26% of patients have a colonoscopy within 30 days, and 56% have a colonoscopy within 45 days. Thanks, Brooke. So the benefits of direct access is we have a standardized bowel prep and support for GPs, and this gives patients improved access, improved outcomes, and a better experience. This patients, the GPs can help prevent delays to colonoscopy, and there's a lot of reasons why patients are delayed, and the most common ones are the patient is uncontactable. So it's really important to have their correct details and phone number. If they're seen in outpatients department, it often takes longer to schedule an appointment. If they don't show for the procedure, then it's delayed. So they don't show for the procedure, or they don't show in the outpatients department. So then they need to be contacted again. Sometimes the patient defers because they're unwell or they're on holidays. Sometimes the endoscopist defers because we are a public hospital and we have to prioritise our sicker patients that may be inpatients. And there has been a lot of deferred due to COVID when the endoscopy clinic was closed for 3 months. So encouragement by GPs and practice staff substantially boosts participation in colorectal cancer screening. Patient endorsement letters in advance of receiving a test kit, and the use of GP reminder systems and practice audits are approaches likely to improve participation rates. And increased participation rates in the national screening program will increase the program's effectiveness and cost effectiveness. You can see that by this graph that our median waiting times have reduced since we rolled out the direct access colonoscopy service, and we're hoping that will continue. Thanks, Brooke. So as part of the Better Value Care program, we're ensuring the patient experience is a positive one. Audit and patient survey results are shared with stakeholders and let us continue to improve the service. This graph shows that 70% of direct access colonoscopy patients had precancerous lesions removed, and 3 revealed adenocarcinoma. So certainly the program is worthwhile. With updates in our electronic medical record system, we're moving towards emailing results to GPs. So having practice email addresses is essential. And if you need more information, you can contact Dr. David Williams, who's our head of gastroenterology, or myself, who is the coordinator. Thank you. And I'm just going to hand back over to Sarah to facilitate any questions.
Great, thanks Helen, and thanks to Brooke, to Laura, to Chris and Rose for your presentations. Now, this next section we've allowed about 10 minutes or 15 minutes or however long we need to answer any of your questions. We've had one come through which we might start with, and I'll ask Rose or Chris to speak to this one. But the question is, why do you think the at-home bowel screening rate is low?
Hi there, can you hear me?
Yeah.
The question was, sorry, why do we think the participation rate is low? I think it's
yes.
There's quite a few factors I think involved. One is the awareness that I talked about, and the fact that that has been, we've done quite a lot of work to build that awareness for the last few years. You would have seen mass marketing campaigns on TV for the first 6 months of last year and this year. And that's really when we've been able to go into the field with things that have broad reach. People have not been aware that it's the problem that it is, where they are aware of things like lung and prostate cancer, for example, and breast cancer. Part of that is to do with the amount of conversation that goes on. And one of the things that we picked up quite commonly in our focus testing for campaigns, when we try to sort of sense why people aren't doing screening, is comments like, you know, if it were important, the government would be doing something about it. Now, we're talking about a couple of years back where people were only getting a kit once every 5 years. In 2015, people were only invited once every 5 years. So they weren't seeing kits very often. And there were no ads on TV. It just seemed like a non-problem to them at the time. It was just not something that was grabbing their attention. I think there's a stigma attached to it. And look, there's quite a few of those for different cultural groups. And there is a whole range of things here and can be related to health literacy as well. But there is a squick factor. There is a certain idea of misconception about it being a dirty thing to do because people think they're going to get their hands dirty or they're going to have to handle their poo. One of the things we see is that the participation rate for initial screeners, first-time screeners, someone who hasn't done the kit before, is down around 20%. The rescreening rate for somebody who took part 2 years beforehand is about 76%. So there's 3 times more likely to do the test if they've done it before. And I think there's something there as well, that it's not as difficult as people think it is. It's not as dirty as they think it's going to be. It's a nice peace of mind to have done it and gotten a positive result. And it's nice to do it, I think, even if you get a negative result and then follow it up to find out that we got something early. So that's a reinforcing, and we hear that story. And I think that's a really powerful story for people. So we asked people, I think we surveyed 500 people a few years back to find out what their biggest influences were. And more than 90% of people said, if my GP told me to do the test, I'd do it. But they send it to my house and I don't think it's necessarily important or it's necessarily the right test. But if my GP told me to do it, I'd do it. So there's that, and I'm aware that primary care weren't engaged, and GPs weren't really engaged at the outset when this program was developed. And I think there were some points missed there in not having done that, because primary care has a real role here in getting people to screen and encouraging that participation, but they've not been part of the development of the solution. And I guess the last point I'd make too is it's actually only just finished being rolled out. Breast screening has been with us now for over 20 years. Bowel screening has just finished this implementation. So I agree, on the one hand, the participation rate is actually really bad at 40%, but also for a program that finished rolling out last year, it's at 40%, and that's not a bad sort of starting point. So there's a lot to build here. 33% in 2015 equated to a couple of 100,000 tests in New South Wales, where 38% a couple of years ago equated to something like 850,000 tests. So as the percentage hasn't actually changed as much as the number of people doing kits. So it's a complicated picture, and I don't want that to sound like a cop-out. We do need to get that participation rate up, and we're doing everything we can to do that, but we are seeing an increase in screening, and we are seeing, importantly, I think, a real increase in awareness, and we certainly see that in our campaign evaluation, where we survey thousands of people to understand what their perception of bowel cancer was before and after we run a campaign. We are building that awareness. So I'm aware I've just taken up a lot of time for that answer. I hope that was okay.
That was really great, Chris. The take home really there is we should all be comfortable talking about our bowels. And if your patients are over 50, that should be the first question from your lips. Have you done a bowel screen? I might just throw to Brooke and Laura, as they've done a few of these sessions before with GPs, and just, I guess, think about some of the usual questions that they get asked, and if they've got any extra information they want to give you now as to what are some of the questions GPs often ask.
Thanks, Sarah. I think often in regards to sort of GPs taking up a direct access service, what we do here is sometimes there is a reluctance because it is sort of steering away from the typical referral pathway. I think this does come down to maybe having confidence in the model itself and potentially having been involved in the co-design of that model. And certainly we have encouraged and now have observed that many of the successful governance structures and steering committees have GP representation on that committee, I guess, to build acceptance of the model and implementation of that model through their PHNs. I guess the other thing is, the GP's capacity to have that discussion with the patient about, their suitability for that type of pathway or a DAC pathway. Certainly we know that there are people in our community that are sort of highly anxious, and a telephone triage assessment possibly wouldn't be appropriate for them, and they would feel more comfortable going to that outpatient clinic or going to that specialist private rooms. But I do think there is a place for direct access, and there is certainly a place to have those discussions with your patients about the different pathways available to them and the pros and cons of each of those pathways.
Great, thanks, Brooke. Anything you would like to add, Laura?
I think Brooke covered it really well.
Great. I might just flick to Dr. Williams. So David Williams is our head of gastroenterology at St. Vincent's. David, you can move closer to the screen. I guess one of the things here is that private specialist versus the public health service conversation, which we know is out there for our patients. And we want to give our patients a choice as to where they're referred to. But I guess what would your take home be, David, for our GPs as to when they're making that decision?
I think the usual rules apply. I think there's no doubt that the public hospital still has huge demand because these services are great forward in terms of access and availability.
You might just have to come closer to the microphone, David.
Can you hear me now?
Perfect.
Yeah. Look, I think the usual rules would still apply. I think if the general practitioner's referral pathways are through their private practice rooms for most patients, it's still not an issue as far as I'm concerned. Once, however, that patient gets referred to the public hospital, we aim to be much more efficient in handling that request for admission, whether it comes via rooms or through the general practitioner. I think we're trying to create equity of access for everyone, independent of their financial status, their insurance status, and we want to ensure that no matter where anyone gets a colonoscopy and by whom, they get a quality procedure. But there's still large demands on the public hospital, and I think there's no doubt we would struggle to probably sort of have the same sort of times from referral to colonoscopy as might be done in more private facilities. but obviously there's a cost to that for the patients, and where it's not feasible, you know, we're aiming to provide as good a possible service as we can. And the take-home message is that if anyone has their mother have a colonoscopy, we want to ensure that St. Vincent's, they're going to get a great colonoscopy.
Great, thanks, David. Now I might just put it back out to the room and those online. If you've got any questions, now's the time to put them in the chat box. Rose and Chris, is there anything else you'd like to add? You first, Rose. From me, maybe Chris. From you?
No, nothing from me.
Great.
I guess just something that we have learned over time from our participants that we, you know, we do follow up or we have interactions with, is that it can be quite hard, as I mentioned before, to get somebody to do the test. There's quite a few barriers we need to overcome. They need to be getting the tests delivered, for example, in the first place. Then understand that bowel cancer is something they should worry about. Then understand that the test is something that can help them through this, and then feel like they've got the personal efficacy to actually undertake the test and send the result back and follow up with their GP and get a referral and go and get a booking for a colonoscopy. And it's heartbreaking to hear them when we're trying to follow up and find out why they've decided not to go and have a colonoscopy, that their answer is, well, I did hear that it's really important to do the test, so I did the test, and then they referred me for a colonoscopy, and then I was told it's going to be a 10-month wait. And I'm not going to live for the next 10 months with the weight of a possible cancer diagnosis on me. So I'm just not going to think about it. I'm not doing the test again, and I'm not going in for a colonoscopy. And to hear somebody has completely detached from the program, and obviously that's not everyone, but that is, you know, in a sense, what happens when we can put people under that sort of pressure. We do have, as a health system generally, if we're going to screen people, and it really is important that we screen them, we do have an obligation to make sure that they can get the diagnostic assessment and the treatment they need. And I think direct access goes a real way to trying to remove the wait for the wait in this, as well as improving the experience that we're giving them. And so I really applaud the work that's being done here. And I, you know, I hope that we do also increase the, you know, the pathway and the referral streams that we have between primary care and secondary care, and help strengthen that relationship. I know in some of the direct access clinics we've had that have been more well established, it actually has led to far closer relationships between primary carers and specialists at the hospital, partly because, you know, GPs have reached out and wanted to know more about how I get my patients in there. And so they've run education sessions probably similar to this, where, you know, networks and connections are made, and that relationship can grow. So I think for a whole range of reasons there, this kind of initiative is really good for building better quality outcomes for everyone.
Thanks, Chris. I think that's a really good summary, and one that we should all take forward. The assumption, I often find that assumption of people having a health literacy to know what to do with it, and also to have the finances to make decisions, often is we assume people's situation, whereas this service, I guess, really allows that equitable access. And it's been such a great experience to work with Helen and David to really look at how we can improve our local colonoscopy services and make them more efficient and accessible for our community that we serve. Now, the last question I've got here, groups try to facilitate public hospital referrals, but still take several weeks, and the process is time-consuming and can be frustrating. It is often easier to send for private appointment, and I get through to the specialist to ensure fast tracking through the public system. So probably a statement question. I might throw to you, David and Helen, locally. Can you reassure this person, one of our colleagues in the audience, who have asked whether on, you know, this frustration with the service, and I guess if you can speak to your experience as to how our service is now, I guess, overcoming that frustration for them.
Oh, the first comment is that remember that this initiative is regarding FOBT and direct access, so that's important. It's very clear. It's been a real learning experience for us. We recognise that we really have to improve our processes and our efficiencies to address all the issues mentioned. The starting point is FOBT. Whenever we receive referrals here, you have to accept that, as I said, we have enormous and huge competing demands So we have to undertake a triage process when we look at the type of referrals that we have, and perhaps the expectation amongst general practitioners, referring doctors and patients is not quite met by what we perceive their triage needs are. And that's a problem, I accept that, but we have a resource issue on our side. We do the best we can. If there is, however, a patient's situation that evolves whilst waiting, we're very open to being contacted to see if we can redress that. My hope is that once we roll this out efficiently and well, we upgrade our endoscopy services, that we can start utilising nurse-led assessments much more than what we do currently, which will then allow freeing up time for more time in outpatient clinics. But it is an issue, and I'm afraid it's never going to be perfect. But there's no doubt we can improve things as time goes on.
Thanks for that, David. Anyone else have a comment on that?
And we're certainly happy for two-way communication between primary health carers and the hospital here to address any problems or any issues that they have with patients. Yeah, great. Thanks, Helen. And Brooke?
I think it does relate to the point somewhat. You know, we found that through the process of collecting the baseline data that a lot of information on those GP referrals weren't carried through the hospital system, and then so from the hospital's perspective it's been very difficult to triage patients correctly, and sort of we're finding now that a few LHDs have actually acted on that and have streamlined processes to make sure that the indication on the GP referral is carried through the hospital system, and then allowing them to triage appropriately and then according to the colonoscopy categorization guidelines.
Yeah, great. Thanks, Brooke. So I don't think there's any more questions in the audience. So I'd really like to take this opportunity to thank our wonderful presenters and panelists, Chris, Rose, Helen and David, Laura and Brooke. And thanks to the Cecilin, as I can never say it, for having us here tonight. I guess there's been a lot of take homes, but I guess to reassure our GPs out there that we're really excited to continue to strengthen our PHN relationships and our primary care relationships, that we are just a phone call away, and that this direct access colonoscopy service is an evidence-based and proven initiative that is rolled out statewide, that is all about improving patients' equitable access to this service after a positive FOBT. So